Thank you for staying with us on Monday, on the Monday Report. As promised, we're discussing diabetes and well-being. That is the theme of this year's World Diabetes Day. We are being hosted by Daystar University, and with me on set, I have Dr. We'll start with Dr. Rosaline Ngugi, and she is chair of the Kenya Diabetes Study Group. Sitting next to her is Executive Director, Non-Communicable Diseases Alliance Kenya, and she is Dr. Kathleen Karekezi. And sitting next to her is a pediatric, and I just usually have to read this just to make sure I'm getting it right, endocrinologist. So she deals with the endocrine glands. I had to Google that one. And yes, that is Dr. Phoebe Wamalwa. And sitting next to her is Dr. Rilwan Aidan Mohammed, and she is Rosaline's vice chair at the Kenya Diabetes Study Group. We also have an audience with us tonight, and they will be engaging. They will ask questions. Please do the same. And the hashtag is Monday Report. You can at me at Obarrows at Citizen TV Kenya. All right, I will start with you, Dr. Karekezi. The numbers I got online when I Googled this from the International Diabetes Federation is that we have 2.3 million cases of diabetes in Kenya, but then it went on to say that 43.7% are undiagnosed. So how do we know that that figure is actually 2.3 million? Is that the data you have?
Well, just to say that we don't have the accurate data. So these are estimates from maybe projections from other countries. But at the moment, it's projected that we have about 6% of deaths in Kenya are due to diabetes. And upwards of 41% of all deaths in the country are actually due to non-communicable diseases, which include diabetes, cardiovascular, cancer, chronic respiratory conditions, and so on. So it's a big burden, and the diabetes burden is increasing. And it's important for us to understand that the majority of diabetes can actually be prevented. And that is why it's important for us to focus on World Diabetes Day and to support people living with diabetes and to create awareness in the community about what diabetes is all about, how one can prevent it, and how one can, if you have diabetes, how you can live positively with diabetes to prevent the onset of long-term chronic conditions, which in most cases can be life-limiting. They are very expensive to manage, and they really compromise the quality of your life. So it's important for us to create awareness in the communities about diabetes, what it's all about, and most importantly, how you can manage it for yourself. Thank you.
So globally, Dr. Ngugi, I saw the figure is closer to 50% undiagnosed cases of diabetes. So would diabetes fall under the category of a silent killer?
It's not only that. What we'd like to say is diabetes is a pandemic, and we've got a looming crisis. And the sad fact is that people don't even realize that. You know, you say 50% are undiagnosed. The other 50 that are diagnosed, less than half of them are actually getting to target. And then of those, they already have up to 50% having complications. You know, the problem with diabetes is it will not make you go to the hospital because of pain. All you'll do is you find yourself losing weight, you're tired all the time, you find yourself constantly wanting to drink water, and because of that, you're constantly passing urine. And then on top of that, you find yourself suddenly craving sodas and fruit juices. Have you found that one relative who's always asking for sodas all the time, and he's like, I can't seem to quench my thirst? Start thinking, could that be diabetes? We have a culture here in Kenya where we only go to hospital when we are unwell, when we are almost having our foot chopped off, when we're almost going blind. We need to change that narrative. And that's why she's talking about, let's talk about preventive strategies rather than curative. You know, now we're in the era where we can reverse diabetes. So why don't we focus on going back to the community? If I can educate you at what it looks like, then it doesn't mean that there is no pain. So let's try and get you early so that we can actually reverse these complications. Then we'd be so much better off. Yes.
So a lot of the, when you say diabetes, many of us think of type 2
yes.
Diabetes. And at that point, I'd like to bring in Dr. Wamalwa. But there are two other types I read, but you are the expert. That type 1 is juvenile, where in my understanding, my very rudimentary layman understanding is that this is mainly affects children, and your pancreas does not produce enough insulin. And then there's another type that's gestational. So this affects mother and child. Perhaps you can help me make sense of that.
Yeah, so that's a good question. We actually have different types of diabetes. Number 1 is type 1 diabetes. We no longer use the word juvenile. It's actually outdated because type 1 diabetes can affect children, it can affect adolescents, it can affect young adults, and even older adults. And it's usually caused by the body's inability to secrete insulin. So why does the body not come to a point of not secreting insulin? It's because the pancreas has been destroyed to an extent that it's not able to keep up with the demands of the body in terms of insulin. And then we have the second type, which is type 2 diabetes. Now, type 2 diabetes is a condition that affects mainly adolescents who are obese or overweight and adults. So what causes type 2 diabetes? It's because the insulin is produced by the pancreas, but there is resistance to its action at the point of its, the tissue level. But in some cases, because of poor control of sugars, you may also have reduced secretion of insulin. So both can happen in one patient. And then we have the third type, which is gestational diabetes. And this is the type of diabetes that affects pregnant women. So you find a woman was, before conception, this lady did not have diabetes. But after conception, we have a rise of sugars persistently in the body. And upon delivery, you find the sugars tend to go back to normal. However, it's important to be aware of it because if it's not handled well, then the child may develop certain complications, sometimes even losing the child or developing some congenital abnormalities. And then, of course, we have other rarer types of diabetes.
Really?
Yes, yes.
Oh, okay.
Yeah, so these are basically caused by defects in the genes. So a patient is born with them. And a common type that we have in the pediatric population is what we call neonatal diabetes. So if you find a child who is aged 6 months and below developing persistently high sugars, then you have to think of neonatal diabetes. But then also young adults can get those genetic defects manifesting in the family where you find every generation has an affected individual. Then, of course, you have to think of genetic defects. Yeah.
All right. So, but 90% of the cases, though, are the type 2, which are lifestyle related.
Yes.
So my understanding, and you can help me here, Dr. Aidan, is that either you develop a resistance to insulin, or what's the alternative?
Okay. Before I come to that, probably another type is secondary to other hormonal conditions where you have like excess growth hormone, excess cortisol, so you tend to have that. But also there are other, another type is where you have secondary to some medications that we give for some conditions like steroids.
Really?
Yeah, we have what we call steroid-induced diabetes. And a lot of the steroid cases we get are patients who are asthmatic and they are popping the small pill prednisolone for over a long period of time, so they tend to get diabetes as a result of that. So coming to your question about the development of the type 2 diabetes, how it occurs, it's just as Dr. Wamalwa has mentioned, due to the resistance of your tissues, your body, to the insulin that's being produced. And in most cases, these are secondary to obesity, where you have probably as how we explain it is as a lock and a key. So where the insulin is the key and you come and open, so this is now resisting, so it cannot function as it should.
So but the glucose in the blood, so you eat food, right?
Yes.
Then
glucose
there's
gets
glucose
the blood.
in the blood.
Yep.
So you need the insulin for the glucose to access the cells.
Yes.
Okay.
So now this is being prevented. Hence you have excess blood, excess sugar in the blood. And so as a result of that, what happens is you're putting your pancreas under a lot of pressure. So as she said, these patients eventually can also end up using insulin like the type 1 diabetes patients, because their pancreas eventually sort of dies down in terms the beta cells, the cells that produce the insulin actually tends to stop producing the insulin completely in the type 2 diabetes patients. So this happens when patients have been having prolonged uncontrolled diabetes over
like almost 15 to 20 years. So they end up being treated like now they're type 1, completely dependent on insulin. So I'm putting this out because we have patients who come and say type 2 is just essentially oral tembe ya kumeza. No, type 2s can also use insulin as a result of that pathophysiological changes. Yeah.
So why is it bad to have all this glucose in your blood?
When it's toxic, it goes to your brain, you start forgetting, so you get early dementia. It goes to your eyes, you get cataracts. So imagine you're 50 at the prime of your life, you're a CEO and you can't see. Then it goes to your heart and makes it a bit enlarged, so it doesn't beat as well as it should be. Then affects your nerves, so all of a sudden you start getting tingling sensation. By the time you're numb, I will stab my toe against that table, I'll not feel it. And I have a wound, and someone notices, you've had this wound for a few weeks. Because I'm not feeling pain, that's how you can have a wound for 3-4 weeks, and by the time you're presenting to me, I've probably checked your blood supply, and it's not good, and that's how we end up with an amputation. Now it goes and affects your kidney, and your kidney starts, part of the kidney's function is to filter and make sure that the glucose goes back into the system to be used. Now when the glucose becomes toxic to the kidney, now you start losing proteins, and that's how you end up with kidney failure. You end up on dialysis. You either require transplant or you're on dialysis lifelong. So if you think about it then, and you have all this glucose is a very good media for infections. So you're always in hospital, you have persistent flus that end up becoming pneumonia, persistent urinary tract infections. So you even find a male patient coming in with urine infections and you're wondering, why would I get it and I'm a man? And they're being treated like it's an STI and a sexually transmitted infection. Check your sugar. You'd be surprised at what diabetes does. So why are we talking about this? These complications is what is now using up our GDP when it comes to management of diabetes. Why do we have such a high economic burden? Because we are not aware of the effects, the complications of diabetes. Then they end up coming with, imagine picture one of my patients who walked in, a 25-year-old comes with a heart attack. I got a 40-year-old with a stroke. These are people in the prime of their life. But had we educated them about the risks of diabetes, just screening, you'd actually prevent some of these complications. So diabetes is a killer, and that is why we are talking about this year's theme of diabetes and well-being. It's not just about the medicine. It's what kind of lifestyle are you leading? What kind of diet are you having? Are you doing any exercise? Because we need to change the narrative that people always believe, if you're coming to see Dr. Ngugi, all I'm going to do is look at your sugar, look at the sugar chart, write for you a script. It's not about that. Now we believe we can reverse diabetes. So come early. You actually stand a chance that we can put it into remission for 5 to 10 years before you know your pancreas now cannot be able to produce insulin, and now we're back where we started. But what we're saying is there is hope, that only if you catch it early. But even for the ones who have complications, we can prevent progression, because now we even have drugs. We have technology. It's interesting. Before, with monitoring, people could not afford monitoring devices. And so the only time you come to see us, once in 6 months, we do your sugar, and depending on what you eat, we say whether you've been good or bad. Now, we can be able to tell how your sugars have been for 3 months, and that's called a glycated hemoglobin. We even have technology called continuous glucose monitoring. And all you do is you place it on the arm and tap with your Android phone, and you can tell how your sugar is. So when you're in the middle of a meeting, and Olive, you're called, your boss is really stressed, you start sweating, tap your phone, you're like, my sugar is low. And you drink your cup of tea and you're good. That's how amazing technology is when it comes to the field of diabetes. So we're learning a lot. But the problem is, I feel like in as much as we have got all this technology, we've left behind one important thing. How many people know what diabetes is? You probably have 1 or 2 relatives who have diabetes, right? How many times have you actually said, as I have brought my mother to see you in hospital, have you ever bothered to just check your blood sugar? You're at risk because your mother has it. Your grandmother had it. Why don't you just check? You might not have it. Your children can, though. So what can we do to prevent this from passing on to generations?
All right.
And that's why we're having this conversation.
And I would also like to look at what the risk factors are, the people who should be more cautious than others.
Yes.
But Dr. Karekezi, in 2020, WHO member states endorsed 5 global diabetes coverage targets to be achieved by 2030. 80% of people with diabetes are diagnosed. That's the vision by 2030. 80% of people with diagnosed diabetes have good control of glycemia. Another of the targets. 80% of people with diagnosed diabetes have good control of blood pressure. 60% of people with diabetes of 40 years or older receive statins. That one you'll have to explain. And 100% of people with type 1 diabetes have access to affordable insulin and blood glucose self-monitoring. Where are we in achieving these targets?
Okay. Not to be pessimistic, but we are heading there. We are not there yet, and we still have a long way to go. For example, in terms...
All right, I'm so sorry, Dr. Karekezi, we need to sort out your mic. Yes, yes. But even, would you like to chime in on that one, or? Yeah. Okay.
Yeah, I just want to agree with Dr. Karekezi's introductory remarks that we are headed there. We have a long, long way to go. In terms of diagnosis, especially on type 1 diabetes, the statistics are even more grave, because around 65% of our children and adolescents, young adults with type 1 diabetes are undiagnosed. And the interesting thing is we are misdiagnosing them out of just misdiagnosing or putting a wrong diagnosis like other common childhood conditions. Because type 1 diabetes, when they present with it in the hospital, it can mimic diagnoses like meningitis, pneumonia, even diarrhea, vomiting, gastritis. And so that is where misdiagnosis comes in, and hence underdiagnosis. So what we need to do as a country or as a nation is to put in more effort on creation of community awareness in terms of just educating the community about the 3 classical symptom or presentation of type 1 and type 2 diabetes. Okay, if you're passing too much urine, if you're taking in too much water, and you have weight loss, then you're more likely to have diabetes. When it comes to management, that is where we have a big problem because of the availability of the commodities. We have erratic supply of insulin in our facilities, the glucose monitoring devices and the strips, because for these children to survive and thrive, they need to be injecting themselves multiple daily injections or doses per day. And that one has to be accompanied by constant monitoring of sugars. But we do not have the necessary commodities. And so we are not able to monitor their glycemic control. In terms of complications, again, the HbA1c, as Dr. Ngugi had said, again, it's a real problem in our facilities. And you look at even the insurance packages that our patients have been placed on. We're supposed to be having a 3-monthly HbA1c test, but they have been put on once yearly HbA1c test. And so that one, of course, becomes a major gap in managing this. And of course, just general gaps amongst the healthcare workers in terms of the knowledge, the know-how, and the multidisciplinary team that need to be put in place to ensure that these patients have proper optimal control. So we have a long way to go. But there are immense efforts that are being put in by partners, by the Ministry of Health and the societies like Pediatric Endocrine Society of Kenya, KDSG, and even the various NGOs to ensure that at least we try to, even if we don't meet the target, we get closer to the target.
Mm-hmm. Dr. Karekezi, your microphone should be fine now. Anything you would like to add to that?
I think Dr. Ari has said most of it. Mm-hmm. We are on the way. We still have a long way to go. And especially in terms of monitoring, even for adults or other type 2 diabetes, people having access to glucometers to check their sugars, having access to the medicines is also a challenge. And then also, in addition to all those targets, We also need to look at the psychosocial component of diabetes, because one is living with this condition 365 days in a year, 24 hours in a day. You're worried about sugar control, your sugar going down, getting a hypo, going into a coma. You're also worried about long-term complications. And there are many things that people are concerned about. So we really need to look at managing diabetes holistically. It's not just about the medicines. We need to have the psychological component to the management, as well as the education, and just enabling people understand what diabetes is all about, and the fact that you can live you can live a good life if you know what to do, and if somebody helps you along the way. Having support groups for people to share experiences about their own condition, how they manage different things. So there's a lot of things that need to be in place for you to manage your diabetes better. It's not just about the medicines. Yeah, that's what I like to say.
And Dr. Aidan, how critical is monitoring? Is that the difference between going blind, losing a limb, going on dialysis?
Yeah, so probably on the previous point, the 60% statins. So statins are what we call cholesterol lowering drugs, and it's been critically put there because the main driver of mortality, or rather the main cause of death in our diabetes patients, is actually heart attacks, strokes. So cholesterol lowering medications reduce this risk in these patients. So that's why we're talking about patients above 40 who are living with diabetes should actually be, at least WHO stated, at least 60% of them should be on these drugs. So coming to your questions as regards to monitoring, without monitoring, if a patient comes to my clinic, I am blind on how I will manage this patient, because sugars fluctuate. They're not constantly good or they're not constantly bad. So the monitoring helps us in therapy modification, in the sense that you tend to see some people have highs probably post-lunch, and then they tend to have, coming towards the evening, the sugars are low. So we are balancing lifestyle management together with medication. So when do they usually have their exercise? So this actually, what Rosie has mentioned, the gold standard of monitoring right now globally is actually continuous glucose monitoring, where it's really costly, so we're not even talking about that now. So based on the patient, depending on the patient, the timing of monitoring differs for every patient, obviously apart from the type 1s who have to do before and after every meal. For our type 2 patients, it depends on the management they're on, and it depends on the comorbidity in terms of if they're already having kidney failure. So these patients are highly prone to having low sugars, because probably post-dialysis, or the type of therapy that we use in kidney failure is mostly insulin, which tends to drop sugars. So the monitoring becomes a bit more as compared to a newly diagnosed young patient who is probably capable of being reversed or going into remission. So monitoring varies depending on the patient case. Okay. It's highly individualized.
All right, so we have an opportunity now to take questions from those who are joining us in the audience. Anybody with a question? We have Gina who will pass the microphone on to you. Okay, there's a gentleman in glasses, and there's another one sitting next to him. So you done with the microphone? You have one. So we'll do this group first, guys, and then we'll come to the two of you. So you can start and then pass it behind you. Go ahead. Okay. Don't forget to introduce yourself.
Okay.
Or you can just sit, Umesema kamera ita zoom. Upate sura.
Okay, my name is Geoffrey Michael. I am a student at the University of Nairobi. My questions how does diabetes impact pregnancy and childbirth?
Okay, the gestational diabetes we mentioned earlier, or just in general?
In general.
If somebody has diabetes?
Yeah.
Oh, okay, so how does that affect pregnancy and childbirth?
Yeah.
All right, great. So thank you, Geoffrey. You can pass it right behind you.
Thank you, Rivo, and thanks for the good panelists you have. My name is Samuel Buru, a reader from the informal sector. My question is the level of awareness. Currently, there's a this immunization for polio, which is active up to now. If you ask a certain mama mzee uko nyumbani, atakwambia kuna shindano inadungwa mtoto. Ukienda kwa kanisa, our pastor atakwambia we have this is an immunization week regarding polio. Coming back now to diabetes, I guess this should raise the level of awareness. Kama sasa hata nikienda huko nje nitaona posters zinasema juu ya polio. But now for diabetic, unless labda wale wanaoch screen sahi, ama maybe kuna mtu akona relative ama rafiki mwenye ana manage hii condition, yeye tu ndiye anajua hiyo mambo. So I would recommend two things. One, venye tunafanya hiyo mambo ya polio na hizo zingine, let's we adopt hiyo style. Two, sisi zote we usually attend final services for our relatives. Ni ukweli? In that eulogy, pale chini kuna place inakuwa imeandikwa the cause of death. Kama huyu mtu alipata accident kwa barabara, inakuwa imeandikwa vizuri. Lakini kama ni hizi magonjwa zingine haikuwa imeandikwa. At one of the level of awareness, tunafaa kuifanya in such functions, kwa sababu tuko na watu wengi. Wale mtu akijua fulani alikufa sababu ya ugonjwa wa sukari, na venye alikuanga, huyo mtu akitoka hapo hata arudi nyumbani kwao atakuwa amebadilisha nini mawazo ama hizo haun mindset kuendesha nini. So I kindly appeal to our panelists.
All right. You can
the
pass
level
the mic.
Of awareness.
All right, to the gentleman in the red set. Alikuwa ameinua mkono kwanza. And then we'll take those ones first, and then I'll come here and go there. Is that fair? Okay. All right.
Okay. My name is Duncan Mwangi. My main concern is still on awareness, but this time when it comes to job opportunities, most often, ikijulikana that you're diabetic, the person who is supposed to employ you to give you a job, they shy away from that. Probably because they don't understand how to manage somebody who is undergoing diabetes, because that information is not there. I don't know what we can do. As I also don't know whether we have policies which guide to that. But I still feel policies might not necessarily work. Kama awareness, because if I am a boss and I'm supposed to employ somebody, it is good for me to know how to manage this person. And it's quagga and woga, anything can happen. I think much need to be done when it comes to awareness. Thank you so much.
Thank you, Duncan. Na nimeambiwa, in the interest of gender balance, there's the lady in the brown coat. Yes. Please. Sorry, if you can just please, I'll come back to you. You can just pass the lady behind you. The lady straight right behind you.
Hello.
Hello.
My name's Florence Kamau. I'm a type 2 diabetic, and I'm a leader of a support group, which is a member of NCDA Kenya, where we have Dr. Karekezi. And my question is on the pediatric, the children. You see that in the schools we have kids who have type 1 diabetic, and they live under stigma. There's need for even awareness in our schools, starting from kindergartens, so that the other children are able to run to stay with this kid who is type 1 diabetic, and to love those kids so that they are not stigmatized. Thank you.
All right, we'll start with those ones. And I have not forgotten, you have a question. You also have a question. The lady, there's that other gentleman there. We'll come back with you. But let's start with, so awareness appears to be a big issue. But we can start with Geoffrey's question. And I think that one will go to Dr. Wamalwa. Are you equipped to handle that one? If you have diabetes and you're expecting, how will that impact you?
We can answer both. I can answer on the baby side, then they can answer on the pregnant mother side.
Dr. Eden, you can go ahead.
Yeah. So when it comes to diabetes in pregnancy, there is what you talked about, the GDM, gestational diabetes. So gestational diabetes occurs in pregnancy, and post-pregnancy, the symptoms actually go away up to 6 weeks. it goes away. But these patients are at high risk of developing type 2 diabetes. So when you talk about risk factors, is one of those is those who had gestational diabetes and who had big babies at delivery, babies above 4 kgs. Yeah, 3.94 kg, babies above that. So management of these patients is similar to management of we have type 2 diabetes patients who also get pregnant. We have type 1 diabetes patients who also get pregnant. So management of diabetes in pregnancy is similar in the sense that we have more stricter controls of sugars when it comes to diabetes in pregnancy as compared to patients who have type 2 diabetes or type 1 diabetes. So when we talk about fasting sugars of type 2 diabetes being probably you can go up to 6, we say these patients up to 5.4, 5.6, we don't want you to go beyond that. So we want very strict controls for these patients. So the monitoring therefore happens to be more than the usual when you're usually having type 2 diabetes. Okay? When it comes to therapy, we don't have a lot of medications which are safe in pregnancy because trials with people who are pregnant are usually not done that much. So we only have two actually oral therapies in terms of one metformin. In the country we only use one, and then the rest is insulin. So this actually becomes a question back and forth when we now tell our patients, now you have to go on injections. So a lot of times post-pregnancy, they go off it because pregnancy is a physiological state where now there are a lot of changes in the body. So the sugar control has to be controlled well, and these changes disturb sugars as well. So these are patients we monitor very closely because they have the risk of losing the pregnancy if the sugar is not well controlled. So patients who come to us and are trying to conceive and they have uncontrolled sugars, we advise them to not try until we get the sugars at least within control. So it's very important for patients who have diabetes to see their healthcare professionals early, so we start supplementing them even early enough with the folic acid because of the risk of complications that can develop with the baby. So it's a high risk actually management when it comes to patients living with who are pregnant having diabetes. Yeah.
All right. On top of that, now the impact on the baby is so grave because.
Sorry, did you want to finish with the mother?
Okay. Another impact. He talked about delivery. And you know, if you have a big baby, that also influences the choice of delivery. So you'll end up having more ladies going through cesarean section than normal deliveries because also this baby can't handle passage through the birth canal. And so you'll find, now that's a cost implication because a mother came anticipating on a normal delivery and then now you end up having a big baby and the risks of the child getting complications, which Dr. Wamalwa will talk about, then goes up. So that also has an influence on the cost, and so we have to be very tight with our control. And if we don't control the sugar as well during the pregnancy, then even after the baby is delivered, you start to have mental development issues. When the child is actually in grade 1 and 2, yet when they began with the milestones, they were completely okay. But then you find they're slow in catching up, which is where now Dr. Wamalwa comes in. So we have to be very careful and very strict with our control for our pregnant mothers. Yeah.
Okay, thank you, Rosie, for that introduction. So now the children will be born big. So the delivery may actually negatively impact on this baby because the child may be born with fractures. Some of them may have nerve complications because of that difficult delivery. But remember, this child has been in the mother's womb where there is free flow of glucose through the placenta. And as a result of that, we have high levels of insulin in the baby. Now, immediately you cut off the placenta, we cut off the glucose flow from the placenta. But the insulin levels are still circulating in the baby's body. So you run a risk of having low sugars in the baby immediately after birth, and if you can't monitor that well, you can lose the child. Remember, there's also a risk of congenital abnormalities, and the most common abnormality we normally talk about is a heart defect, a hole in the heart. Or you find that the heart muscle is so thick that the heart is not able to perform its normal function. So that alone can also cause instant death in that neonate. But besides that, again, we have a lot of red blood cells that have been built up in the utero. So they have to be broken down. As they get broken down, the child will develop what we call jaundice or yellowness of the eyes. Again, if it's not managed well, you can have complications. And of course, electrolyte imbalances. The calcium, the magnesium imbalances will be there. But that's not all. If this child pulls through that neonatal period and starts living normally as a child, if you do not manage that child well, the child may also get what we call metabolic syndrome. They may develop diabetes later on, they may develop cholesterol issues later on, they may develop high blood pressure later on, and they may end up in the state where the mother was, gestational diabetes. So it becomes a vicious cycle, and so the only remedy is to break this vicious cycle by ensuring that we optimally manage this pregnant mother who has gestational diabetes.
To be honest, I am terrified to all of that. I would like us to take a break. I know we have questions which are pending, especially on the questions of awareness and stigma. Dr. Karekezi, I'll have you handle those when we come back with the contribution from the rest of the panelists. I promise to take more questions. We will take them on the other side of this break.